I want to thank everyone for attending today's American College of Healthcare Architects Town Hall. I'm Deb Smith. I'm Treasurer and President-elect of the ACHA. We're fortunate to have two of the speakers from the Facility Guideline Institute with us today. As a member of the Health Guidelines Revision Committee myself of the FGI, I look forward to you all hearing about the changes that have come about to the proposed 2026 guidelines and to have the opportunity to comment on those changes prior to September 31st. So I will now turn the session over to Kyle Basilis to get the session started. Thanks, Kyle.
Thanks, Deb. My name is Kyle Basilis. I'm a co-chair of the Continuing Competency Committee, and we've put together this town hall for this quarter. A little bit of housekeeping before. Stay tuned to the chat where we'll be posting how to submit for your HSW credit. So Emily will be putting that in later in the presentation. And I will be monitoring the Q&A. And when we get to that point of the presentation, we will start to review some of your questions and get some answers. If we don't make it to all the Q&A before the end, we'll get those answers from both Heather and John and recirculate it back to the group. So I'll hand it over to Heather and John, who will be our presenters from the Facility Guidelines Institute.
Great. Thanks, Kyle. Thanks, Deb. Welcome to the ACHA Town Hall, everybody. Thank you so much to the American College of Healthcare Architects for inviting us to talk about the drafts of the 2026 FGI codes for health and residential care facilities. So first, some introductions. My name is Heather Livingston, and I am the current CEO of FGI. I've been working for FGI for 13 years and was formerly the Chief Operating Officer, as well as the Managing Editor of the guidelines documents. Before working for FGI, I worked at AIA National and the American Architectural Foundation, which is now referred to as the Architects Foundation. With me today is John Williams, and John is a man who wears many hats. He is Executive Director of Construction Review Services for the Washington State Department of Health. He's Chair of the 2026 FGI Health Guidelines Revision Committee. He is also our VP of Content and Outreach, and he's co-host with Bridget McDougall of our Between the Lines with FGI podcast, which is now just beginning its second season. So, John, do you want to take a moment to say anything?
I think you got it covered. Thanks, Heather.
Okay, great. We have some really interesting developments in the 2026 FGI code documents and are excited to share them with you. So let's get to it. First, I should say this presentation is protected by copyright, so please reach out to FGI if you do wish to share the presentation with a different audience than what's here today. Also, what John and I say here today are our own ideas and opinions. They are not necessarily reflective of FGI's position, nor the Health Guidelines Revision Committee's. If during the course of the presentation you do have questions about the information that we're sharing today, please submit your questions using the chat tool. We're going to do our best to respond to all of the questions at the end of the presentation. So today we're going to briefly talk about FGI, the organization, the Health Guidelines Revision Committee that updates FGI's code documents, as well as the code revision process. We're going to then let you know about some very big changes that are planned for the 2026 edition, specifically in how they're going to be structured and how they're going to be packaged for end users. And then we're going to get into some specific text changes in the documents, focusing primarily on post-acute care areas. Finally, we're going to wrap it up with information on how you can contribute to FGI's code revision process.
All right, so maybe a little bit about FGI to start off. FGI is a 501c3 non-for-profit organization funded entirely by development and sale of the guidelines documents themselves. We are passionate about developing evidence-informed, consensus-based standards for healthcare design and residential care facilities. We create documents that are scalable, that are risk-based, and really designed to be used for new construction and renovation of existing facilities. There are 3 different documents. Hopefully many of you are familiar with the ones on the screen. We have one for hospitals, one for outpatient settings, and one for residential care and support settings. There are other documents that we create. Hopefully you've seen our website and seen white papers and other tools and checklists that are available. And we are developing, not developing, we're actually out there with a podcast right now, as Heather mentioned. There are multiple editions of these guidelines currently in use. And on the next slide, if you take a quick look at the map, you can see many other states where these guidelines are adopted. Ideally, we hope that the map becomes completely uniform with that orange color here pretty quickly. And the orange color, of course, is the 2022 version of the guidelines. But we understand that different states adopt different versions of the code for different reasons. In Washington State, we're still in the 2014 version of the guidelines. There was a little thing called the pandemic for the past couple of years that slowed down a lot of our rulemaking processes. And I suspect that's the same for some other states. So hopefully, as people see the new version of the guidelines and get used to them, we'll see this map start to change as well. So the guidelines are developed. These editions are developed every 4 years. We pull together a group of experts from all different walks of life. We have designers, we have engineers, we have authorities in having jurisdiction like myself. We have clinicians, we have folks from academia and research organizations. And we all come together to do this 4-year process of looking at the current documents, looking at new ideas that get submitted, and trying to come up with the very best version of the document to put out there for states to use, for designers to use, and facilities to reference. So that 4-year cycle looks like this. It's really kind of a call and response. We put out the older version or the most current version in the beginning and say, hey, folks, give us your thoughts. Any ideas to change the document, adjust the document, change it, add stuff, delete stuff? Let us know what you want to do. And this call is open for anyone. Anyone can make a proposed change to the document. We get those proposals back, and the committee looks at those, votes on those, weighs cost and benefit, and puts out a draft document. And that's what has just happened at the beginning of the summer. The draft document is out there, and we're starting our, we started our comment period. And that's where we are right now, public comment. Anyone in the public can make a comment on that draft, specifically on the changes that were proposed, and tell us what you think about it, whether you like that idea, you think we need to go in a slightly different direction. And I say we're in this point, but we're in this point for only a couple of more weeks. The comment period ends on September 30th. So that gives us a little over 2 weeks. So it's free to do this work. You can log in, you can create a free membership on our comment website, look at what people are saying, look at what the draft looks like, and put in your own information. And we encourage you to do that. What will happen next is the committee will consider those comments, make final votes, and after an all-hands meeting next spring, we will begin the work of editing that document with hopes of having that prepared and published sometime in the spring of 2026.
So now that we've given you an overview of who we are and where we are in our 2026 code revision process, let's get into the specifics of what's changing. Several times a year, FGI shares big news such as the recent announcement of the Douglas S. Erickson Healthcare Research Award. Hopefully you just caught that earlier this week, as well as the introduction of our new and very entertaining podcast called Between the Lines with FGI. That was at the beginning of this year. If you've not yet listened to the podcast, definitely be sure to check it out. I know that I am biased in this, obviously, but I do believe it does a very good job of explaining complex code and compliance issues in a way that's both fun and engaging. So back to the news announcement. On July 1, we issued a press release calling for the opening of the 2026 code, the 2026 code public comment period. But what could have been missed if you only scan the headlines of that is that there is a significant departure in the 2026 edition from prior editions. In addition to the regular updates that you're used to seeing when we do release a draft, there are some other changes that you can't help but notice as soon as you look at them. These changes have been driven by the way codes and standards are being implemented, being interpreted by the courts, and they've led to some really significant structural changes in how FGI is now dividing its content. But primarily, we want you to know that we are changing how we package and deliver our code documents. So while these changes do mark a significant change from how we've done this before, I do want to assure you that the content, the sensibility, as well as the overall consensus-based approach to revising the documents has not and will not change. So the first and the biggest change that you're going to notice when you do look at the draft is that we're moving away from our very long-standing model of combining both requirements with guidance. The current edition, the 2022 guidelines, it does contain both mandatory code text above the line and non-mandatory appendix language, which is referred to as below the line. When we do release the 2026 edition, we will have removed that guidance from the minimum requirements. And this is going to result in two new sets of offerings that we're calling the FGI Facility Codes and the FGI Handbooks. We do believe that this change is going to make it clear once and for all that the code contains only requirements that are intended to be used by designers and adopted by governments and quality assurance entities. So in the future, what was formerly the appendix is going to live in the handbooks. These handbooks are not only going to maintain the current content with which you're familiar, but they're going to expand on it. They're going to provide more in-depth guidance and detail than we've ever been able to do before, such as explanatory diagrams, checklists, and some other tools that are currently under development as well. But to be clear, it's going to follow, the FGI code is going to follow the same process with opportunities for public input during both a proposal period and a comment period. And the handbooks are being developed using a similar process, but their development is going to be more reliant on subject matter experts who are on the revision committee, and we'll also pull in some other folks as well. So it's going to be a little bit different in an effort to capture some broader perspectives. So the big question is, why are we doing this? And well, why are we doing it now? So there are 4 reasons. First, we needed some clarity. Like we said, for decades, we've really tried very hard to make clear that there's a difference between above the line and below the line requirements and guidance. Unfortunately, those requirements continue to be confused and conflated with the guidance that's in the appendix. We've heard this from a number of you. We've answered a number of queries, requests for interpretations, etc., that show that there still is a lack of understanding in that. So we do believe it's time to once and for all make a clear distinction between the two. The second reason is transparency. We do believe that this change adds not just clarity, but transparency. We do use a transparent process to develop the minimum standards that are adopted by the 40+ states that John just showed you on the adoption map a few minutes ago. So let's go ahead and call the minimum standards what they are. And let's be clear that all of the other material is really guidance or advisory. While we're talking about transparency, I think we've been pretty clear in the past about FGI's need to maintain our intellectual property rights. We've got somebody who's not on mute. I don't know if Kyle, you want to mute that person or you're able to.
I don't know if I have, Emily, can you mute everybody?
I'll go ahead.
Should
It
be all
sounds
set
like it's
now.
better. Yeah. Anyway, we've been pretty clear, I think, about our need to maintain our intellectual property rights in order to support the development of the content. You've probably heard us say a number of times that the proceeds from the guidelines fund the next revision cycle, and that's absolutely true. We protect our intellectual property so that we're able to do that. Separating the code from the extra content that's created by the HGRC is hopefully going to help us do that in light of the shifting regulatory landscape. A third reason is access. So by separating the types of content, we believe that we're actually going to considerably improve access to the requirements. How are we going to do that? Well, for starters, really happy to announce that we're going to have a basic digital version of the 2026 code freely accessible. It's not going to be like today's read-only version where you only get, I think it's 3 views a month with up to 20 pages at a time. It's not going to be like that. It's going to be true unlimited access. Now, if you want features beyond just the basic code, like the ability to request interpretations, or if you need some more robust tools tied to the license, there's going to be a priced option for that. If you want to buy a paperback, you can do that. If you want to get the code plus, the additional things that we've been talking about, the appendix, examples, checklists, drawings, and things like that, those things are going to be in the handbook. So if you need access to this extra content and extra features, there's going to be a charge just like there always has been. But for those of you who might need just the basics, you will now be able to get them for free. And we do believe that these different modes of delivery ultimately are going to democratize access to the FGI codes, which is a great thing. So finally, accuracy. You guys all know machine learning and artificial intelligence are rapidly changing how we understand and how we interact with our world. And this includes, how we're designing buildings, as well as how we develop and understand all sorts of information. There are some organizations who are using FGI's and other standards developments content without permission in order to create some of these tools, but they're doing it without a licensing agreement. So let me say that a little bit differently. Websites and tools that you come across that host FGI content that are not on fgiguidelines.org do not have a licensing agreement with us. And you might be wondering, why does that matter? Well, it matters because we can't guarantee you that the information that you are getting is complete or accurate. So by getting your healthcare design requirements directly from FGI via the free version or paid version for 2026, you will at least have a very clear understanding of the intent, the background, the application of the requirements. We want you to be able to base your designs on a really solid foundation of understanding and trust that the information that you have is both accurate and complete.
All right, now we get to talk about some specifics. I think this year or last year, this cycle, we got about 1,500 proposals, and that's the initial information that comes in with all the folks' different ideas about how to change the guidelines. And when we get all the proposals in from a particular cycle, we kind of step back and get a sense of what that cycle is going to be like, and trends start to emerge. And especially when you step back, you begin to see those trends. You can see interest, you can see commonalities, you sometimes see real and current issues or even interpretations that begin to emerge. This cycle, we heard a lot of interest in exploring ways to address ideas around how to make sure that we're using acute care spaces for what they're really intended to be used for, actual acute care. And while we've titled this presentation around this post-acute care kind of concept, we're using it as a little bit of a term of art. Typically, a post-acute care probably is going to prompt this idea of a rehabilitation or skilled nursing care or something that happens outside of the hospital. We're using it slightly differently today. We're trying to focus on that transition that occurs from when we move from one level of care to another. That's going to be a clear point. We're going to think about and look at a couple of situations for care that occurs in other places, and that may be post-acute, post-hospital care, or it may be options for other types of care, other destinations even, that is not a hospital, but for patients that we often see inside of a hospital. And this directly relates to the adage I think many of us have heard, and we'll see it on the next slide, about access and sustainability, and it's a pretty common adage, and that's we want to provide the right care at the right place at the right time. Incredibly simple phrase, but incredibly difficult to do, given all of the complexities and all of the different components that go into providing that care and complications with reimbursement, staffing, all of the things that makes healthcare complicated. Even if we were to narrow the concept down to one component of healthcare, like patient beds, there are so many complicating factors and so many different options for addressing those complications. So if we consider bed space, your typical medical surgical unit in a hospital, the beds are kind of key for it being a hospital to begin with, and they take up a lot of the space, but moving people through those spaces can be difficult. And we've got folks landing there from lots of different places. Outpatient clinics are sending their urgent and their planned care into those beds. Emergent care, of course, is coming from the emergency department, and that can be unpredictable at times. Operating rooms are sending in their overnight stays, and we've got folks moving down the acuity chain from ICU or some other place. The bed becomes the destination. And that's not to mention transfers from other hospitals that can't adequately provide care for patients, and they're in hunt for a bed at another facility. Hopefully, the med-surg patients are going to stay there for a while, hopefully a few days or less, and are going to discharge on to the next stop in the community. And that could be home, it could be a rehabilitation facility, it could be a new home like a skilled nursing facility or an assisted living facility. So next slide, please, Heather. As you can imagine, bottlenecks or blockages along this pathway can cause just a system-wide backup. If you have patients who are looking for a bed and all the beds are full, this is probably a reason why we see a lot of backups in our emergency departments. You see delays in surgery. You see worsening acuity in some locations, all because of the challenge of finding a particular spot, a bed spot for people to land into. And it's not just about the complexity of medical surgical care. Some places are just harder to get into. Behavioral health, for example. I know in my state, we have a dearth of behavioral health beds, and that discharge from an acute care facility where often those patients end up or start their pathway really cause a blockage. So that's why folks are tracking time of discharge and adjusted length of stay. The term bed blockage is becoming more and more familiar. I've actually heard it from non-healthcare oriented people, just dinner time conversation. People are becoming more and more attuned to the concept that this is a problem in healthcare. And as the public realizes these challenges, we know it's not a new challenge. Next slide, please, Heather. It's not a new problem, and but some locations are reporting that it's getting worse recently. And the causes of those challenges are arguable. The chart here from a recent but rather narrow survey suggests a couple of different causes, like delays from payer issues, clinical reasons, legitimate reasons, those clinical reasons. Trouble finding placement in another facility is a big one, and just the operational complications that go along with that. And that's, again, truly arguable depending on how you calculate those days, how you quantify what a delay is, and the solutions, of course, are many and various. But at the heart of this incredibly complex problem is a strong operational component. And while I'll channel Dave Dagenais and Dana Swenson, some of our longtime FGI facility-based folks, the FGI is not here to drive operational decisions. But the physical environment, the places that we build for operations, can help facilities support new operational decisions, or can help make those operational decisions more effective. So I don't think anything suggested in these proposals in this cycle is meant to be a panacea or a one-size-fits-all solution to solve the problem. But there are some new options that facilities can use. And that's what the new additions in the FGI code are for. Having the facilities or these units are optional, but if you choose to build them, you have to follow the minimum requirements. So let's take a couple of looks at these options for 2026. So the first thing, as Heather said, we call it the guidelines for design construction of hospitals today, but in 2026, it will be the FGI Facility Code for hospitals. Next slide. The post-acute discharge and transfer complication were looked at, and there were two proposals that generated a lot of conversation, and two new areas were proposed to be created. And those two new areas are the post-acute discharge lounge and the discharge or transfer unit. The names of these words are important. The names of these are a little complicated, and they're still kind of floating around. But these spaces were proposed as a way to more quickly turn over patient rooms and providing a safe place for those patients who no longer need acute care to land while they're either waiting for a pickup home or transfer to another post-acute facility. So let's take a look at those in a little bit more detail. The first one is the discharge lounge, working title, and it's for already discharged persons who used to be inpatients. So these folks have already worked their way through the process. They have their discharge paperwork, and they may technically be a patient still of the doctor or the system, but they are no longer inpatients for this particular stay. The inpatient or the discharged patient lounge has to be readily accessible to the discharge pickup room or area, and it has to be separate from public waiting areas. So we're not looking for something that is just another spot in the lobby. There must be 30 square feet per waiting position, and it needs to have direct and remote observation of direct or remote observation of the patient from a reception or control desk, and it needs to have access to a patient toilet. So I've seen a couple of these already in my jurisdiction, and for all intents and purposes, they seem to be successful. But we never had a clear and succinct way of understanding what the requirements should be for these rooms. So the other type of unit is the transfer unit, again, working title. And this is for the patient who is going to be a patient at another facility. So they're still a patient now, and they're going to be a patient, or perhaps a resident might be a better term, of another facility. And this unit can be a standalone unit, or it can be a part of another unit. It's envisioned to have bays or cubicles, or it can even have private or semi-private rooms. A safety risk assessment is going to be the thing that really tells us what the space requirements and the building system components need to be, and what the availability of that emergency equipment needs to be. So it's going to be a really functional kind of space. So based on all the different types of discharges that you can think of, it could be a discharge to a brain trauma unit, or a rehabilitation facility, or a skilled nursing facility, or dementia care facility. All of those patients need different supports and different interventions. So that's why we're really relying on that function to help us understand what's going to go on in that space. Also planned for this space is a nurse station, documentation area, patient toilet room, and nourishment area. Both of these spaces need input from folks like you. We need you to take a look and help us assure that the minimum requirements are appropriate and patient safety will be protected. There's a lot of questions about how long patients will be in this space. And right now, the draft, I don't believe, Heather, correct me if I'm wrong, I don't believe it shows a time. But we've had a lot of conversation about, does there need to be a time and what does that time need to be? So I think that's a great point to get some feedback on. All right, next item.
John, before
yes.
we go on to the next one, do you want to just mention that we did workshop this at the Summer Leadership Summit? I don't know if you want to
We
let
did.
folks know.
We did. We brought this back to the Summer Leadership Summit, broke into different groups and got a lot of really good input. I think the question about how long those patients need to be there was top of the list. What types of patients could be there? Many folks suggested that those maybe behavioral health patients, this wasn't a good spot for them without careful planning. And I think we got some really good input. The hope and the goal is let me go back. There was a lot of interest in this, and when I've taken this out to other communities, people have said that either they have one or they're thinking about doing one, or this is new information and they want to learn a lot more about it. So I think there's a lot of interest from facilities for sure around what this could look like for them. The question is, how do we craft a set of minimum standards that sort of covers all the bases and provides enough flexibility, especially in the transfer unit, to cover all the different types of patients that would go into that space, because it's kind of a tough nut to crack, if you will.
Yeah. All right, thanks. I think that was well covered.
All right. So the other one that we talked about this particular cycle is the hospital document group formed a special task group to really go through the chapter on rehabilitation hospitals that we have in the current document. There hasn't been significant updates for a number of years to that particular document or that particular chapter. And we went through and we looked at a number of different things. First of all, the clearances have been updated. The group agreed that the current clearances and spaces were a bit undersized around the patient bed. And in the toilet room. So we have new requirements too for a toilet room that provides enough space for an attendant to help with patient bathing. So those are some new suggestions. And again, this is a classic post-acute location and destination for people to arrive at. Another thing that we talked about this particular cycle was the concept of long-term acute care hospitals. And those are those hospitals that are really, I mean, I've always described them as ventilator hospitals. So these are folks who are on vents for longer periods of time. And while there is an effort made to wean patients off of these ventilators, and there is a component of rehabilitation therapy, lots of different types of therapies there. This is really for folks who are on ventilators for an extended period of time. We had a request to consider drafting specific requirements for this particular hospital type, and we talked about it with the committee extensively. And at the end of the day, we realized that from our reckoning, there are only a few of these facilities across the country, and we don't see significant growth. And every time that we could find an example in our group of where a new one of these was either stood up or developed, there was examples of people using the current FGI guidelines to work through that development process and getting to good answers. And that's using some of the different approaches that we have in the front of the book. And one of the approaches obviously is to take find the chapter that you're most closest to and follow that chapter. Another approach is to say, okay, you're going to build something completely different. It's going to be amalgam of a couple of different pieces of chapters. And people were finding a lot of success using the existing guidelines to do that. So at the end of the day, we decided not to create a brand new chapter for this, but we are still tracking that. And if we do see a surge or we do see confusion, a lot of times our proposals may be driven by the number of questions we get at FGI. We may revisit this at a later date. And I think that's it for hospitals. I think, Heather, you're going to walk us through some changes in outpatient and residential.
Yep, absolutely. So whereas it was the outpatient guidelines for 22 for the 2026 draft, it's now called the FGI Facility Code for outpatient settings. And just as we're seeing in the hospital code, there's an identified need in outpatient for spaces where care can be provided for patients who may fall between the cracks of inpatient and outpatient care, primarily because of length of stay restrictions. So attend to that need as it relates to ambulatory surgery clinics, new requirements for short stay centers now appear as Chapter 2.15 and the 2026 outpatient draft. This chapter is a simplified version of what was called the extended stay facility that appeared in the 2022 guidelines draft. It didn't make it into the final edition. It stopped at the draft in order to be reworked. So for 26, this version has been thoroughly reviewed, and honestly, it was dialed back so that it's just specific to providing support services to patients receiving care from ASCs. These short stay centers are intended to provide basically a bridge in care until the patient is able to safely travel home. Examples of when a short stay center might be needed include when an ASC patient is released late in the day and maybe they live a long way from the outpatient facility and can't travel the long distance. Or possibly there's no one available to provide any caregiver support at home and they just need a little bit of additional time to be sure that they're going to have a good outcome. Short stay centers are required when they're built. They're not a required facility type, obviously, but if they're being built, then they are required to have all single patient rooms, and they would have minimum square footages that you would expect to see in like a med-surg unit, for example. However, one big difference is that you don't have to have a toilet room attached to every single patient room. It's not a minimum requirement for this, that's what the outpatient document group believed. So instead, they assigned a ratio of 1 toilet room for every 6 patient rooms. Additional minimal supports have been provided, including a means for observation of the patient at the nurse station. This can either be accomplished, though, through either direct eyes on or through an electronic means. And though they're not new for the 2026 edition, behavioral health crisis units also provide post-acute care for patients in lieu of hospitalization. For the 2026 edition, in the outpatient document, behavioral health crisis units were moved out of the freestanding ED chapter. And this was really done in order to make sure that these requirements are easier to find. We've heard from some folks that they were a little buried, not the most logical place to find them. So we thought that it made sense to go ahead and pull them out into their own. So they were initially, the requirements for behavioral health crisis units this cycle were initially proposed to be relocated to Chapter 2.11, which contains all of the outpatient requirements for behavioral and mental health facilities. But when reviewing the text and making that change, the Health Guidelines Revision Committee also decided to add language that would clarify that crisis centers could be located in a freestanding ED, or they could be a community-based crisis center for medically cleared patients. So you've got the 2 different options, which further supported the idea of not having it in the ED, the freestanding ED. So the result of those changes then is that in the draft, you're going to see 2 back-to-back chapters that are dealing with outpatient behavioral and mental health. So the existing Chapter 2.11, as well as the new Chapter 2.12, which is specific requirements for behavioral health crisis centers. Where these centers are provided, there are options for single patient rooms as well as multiple patient observation rooms. For both, a toilet room is going to be required at a ratio of 1 for every patient care station. So regardless of whether it's single or multiple patient. And a med prep room is also going to be required in the community-based crisis center, as well as a calming or comfort room for patients that may become agitated and who need a place of respite while they calm down. So again, not new for 2026, but important to note for post-acute care. Actually, it's not on the screen, but I just wanted to call out our requirements for the inpatient, outpatient, partial hospitalization program, or IOP-PHP. IOPs provide regular intense therapy sessions to patients who are recovering from mental and behavioral health diagnoses, and PHPs support patients who are experiencing a relapse, as well as those who require some additional and substantial step-down services. Neither program provides inpatient care, but they do provide a higher level of support than is commonly available in a traditional outpatient facility, and therefore serve as a conduit to keep from readmission, for example, to a behavioral health hospital. So before I move on to residential, now's a really good time to remind you to submit your questions via the chat tool. We look forward to hearing your thoughts on the changes that are being discussed and hope to have time to answer all of them. So again, a title change for residential. It's no longer the residential guidelines, of course. It's now being called the FGI Facility Code for residential care and support settings. And in that document, in order to support the ongoing health needs of long-term care residents outside of the hospital or outpatient environment, the Health Guidelines Revision Committee added to the nursing home chapters minimal requirements for dialysis treatment areas. The draft of the 2026 residential code features expanded dialysis requirements, and these were done in order to basically support residents who have acute renal injury or end-stage renal disease. You may recall that there were some requirements in the 2022 edition of the residential document that were added to accommodate peritoneal dialysis. Those are still in the document, but they have been moved out of the nursing homes chapter and are now available from the common elements. So that decision was done in recognition of the fact that there may be other facility types that want to provide this service. It's not going to be exclusive to nursing homes. So they've been moved to the common elements so that any residential care facility that is covered by that document can access those requirements. Instead of having residents go to hospitals or go to an outpatient facility for dialysis care, these changes support the idea that John mentioned earlier of having the right service in the right place at the right time. Sometimes you will find that independent living facilities are also considered to be a type of post-acute care. The Health Guidelines Revision Committee disagrees with that categorization. In fact, they believe that an independent living facility is a true residential facility. And in light of that, they have decided to pull that chapter from the 2026 edition. So that was really done in order to make sure that it's not creating conflict with other codes. If it's not a healthcare or support care space, then it doesn't need to be in there. So that's a new change that you will note in the draft. So, and finally, similar to the changes that were made in both hospital and in outpatient regarding spaces for behavioral and mental health care, the draft of the 2026 code also features a new chapter for behavioral and mental health residential treatment facilities. This chapter is intended to provide minimum requirements for facilities that are intending to provide ongoing care and treatment of residents who might have dementia, they might have neurodiverse conditions, or they might have diverse neurocognitive conditions. So they don't actually require acute behavioral and mental health services, but they do have ongoing needs. And so this is in recognition of that and to provide a level of support and basic services for that patient population. So this new chapter really supports the ongoing effort to provide post-acute care services in spaces outside of the traditional hospital and outpatient setting.
So I think you can see sort of why I suggested that we took a little liberty with calling this the post-acute presentation, because we have a couple of different scenarios where it's not post-acute, it's getting the patient to the right spot to begin with. I mean, if you have a behavioral health crisis, maybe an emergency room isn't the best spot for you. Maybe one of these crisis behavioral health provides a much more sensitive and appropriate place. Also, if you're in a skilled nursing facility and you need access to renal dialysis, maybe going to an outpatient or a different location is not the best. Maybe if you can get to it in your home, it's a much better outcome. So if some of these, and honestly, Heather, I think all of these are optional units and facilities that people can choose to design. Why do we write these into the codes to begin with? So I think the answer to that is first and foremost patient safety. And if you could bounce back really quick, Heather, patient safety to begin with. We want safe environments. And even though not every hospital has like an intensive care unit or a burn unit, if you choose to build one of those facilities, there's a lot of risks in the built environment associated with that type of care. And we want to make sure that there is a predictable and understandable approach to putting that physical environment together. We are always looking for that level of minimum safety. The other concept is safe harbor. And that's an opportunity if it's codified in a book, if a group of subject matter experts have gone through a public process and said, all right, this is the minimum standard, you can approach a design and say, all right, I understand that the guidelines are the place to understand where the minimum standards are. And if you design it that way, you've done your due diligence. You have checked that box, and you can always go above and beyond all of those minimum standards, depending on what the facility wants to do or you feel as a designer you need to do. But at least you've got that safe harbor, not just for designers, but for architects, AHJs as well. So the safe harbor is really meant to equip all of folks in that design team with a couple of different things. So next slide. With facilities, these options are going to give them tools that they can choose to use to decompress their inpatient bed census if they want to. We're not mandating any of these again. For AHJs, it gives us a reasonably predictable set of safety mitigations. And for architects, you've got a plan now. You have an example where you can take these ideas to an AHJ and say, hey, we want to design this type of space. Here is a clear set of requirements to follow. I'll tell you, when I saw the first discharge unit probably a decade ago, I didn't know what to do with it because as an AHJ, I feel this weight and this burden of responsibility to make sure that I'm doing the very best to protect patients. It wasn't in the guidelines, so I took a lot more time and a lot more care walking through with the facility and the designer what those minimum standards should be. And that was great because it was an innovative idea at the time, and it ended up being a great benefit to the facility, but it took a lot of time to do. With this in the guidelines, you've got a ready-baked answer. You can approach the AHJ, and it's just like anything else that would be in the guidelines. You can say, hey, AHJ, I'm designing one of these and one of those. Here's the requirements, and here's how we meet them. The trick is, if we call back to that map of which version and which edition is adopted in each state, not all AHJs are going to have access to this information. So it's really up to designers, it's up to facilities and organizations to approach AHJs, encourage AHJs to take a look at these. I know public health is struggling right now. We don't have a lot of time. We're still recovering from a spate of emergencies. But if you want to take advantage of these new requirements, current adoption of current standards is going to be the thing that we want to get to. So with that, I think we're ready for some questions. Oh, actually, I think we want to remind folks that it is time to provide public input on the guidelines. You've got until the end of September. Your thoughts, your ideas. I've already seen many of your questions in the chat, and I think these are great concepts to ask as public comments, some of them. So please log in. It's free. The website is fgiguidelines.net. You can sign up for an account, and as long as you get your comments in by September 30th, those are going to be reviewed by the committee and will form the basis of the next version of the guidelines.
I think it's important to remind folks too that if there are sections, if you're reviewing the draft and you see something and you think, that's a little funky, I'm not sure I agree with that. If there are no comments on that, it automatically goes through into the next version. So if you do review it and find something that you think might not be a minimum, it might go too far, for example, or it might just be, in the wrong location, whatever you find as an issue, if there's not a comment on it, it won't go forward. So please take a little bit of time just to put something in. That way we can continue the conversation.
Absolutely. Now's the time. All right. So now I think we're ready for questions.
The first is, will the online free version be formatted like the books, more like the old Mad Cat versions?
I think
it's interesting.
Yeah, that is an interesting question, because right now our current version actually has both. I don't know if you've noticed or not. There's a PDF view, and then there is also a a digital view. So I think, I don't know about the free version yet. We're honestly still in development of those things, but we do plan on having a paperback book for the 2026 edition. So my guess is that we will also have both views available. But I'm not sure that we're going to have that for the free version, to answer your question. It's to be determined still.
And honestly, we're kind of curious about how folks like to maneuver through this content. As I like my paperback books, and I hear from folks that everybody likes paperbacks. But as we start to develop more and more digital tools, we're curious about how people would want to see those. The digital version that Heather suggests, we have now, looks a whole lot like a book, or can look a lot like a book, and certainly the PDF does as well. But when we start developing tools with different opportunities, we want to take advantage of those digital opportunities as much as we can.
So I have a question then on that, because I use we have a digital subscription. And one of the things, where would we put the comments on things that would help us as digital users of it? Like specifically, like when you do a search key, you get to some pages, but you can't go backwards until you have to re-enter it. Like sometimes when you're like something highlights and it's not a super speedy way to kind of stumble around if the section is what you want. Is that something where should we be commenting on that, on how we kind of the navigation tools for the digital version?
That's a really great question, and we are always looking for feedback on usability. I would say that the most immediate way to bring attention to it is to email us at info@fgiguidelines.org. And that way we can review it. We can talk to our developers. We know that there are some issues with the search, and we are working to improve it for the next edition. Absolutely. But yeah, if you have a usability issue, please definitely let us know. Contact us at info@fgiguidelines.org.
And listen for opportunities to participate in focus groups as we go into developing this handbook, where there's going to be opportunities for the community to let us know what you think about things that you're frustrated about, things that you like, all those kinds of things. So watch for those opportunities as well.
Will there be a requirement for access to daylight in these post-discharge lounges or units?
That's a really good question. I think that would be an excellent comment as we start thinking about timeframes for patient, well, for those no longer patient areas where you're just waiting for a ride. Those are intended to be really short stays. So that probably informs that concept a little bit. So it's arguable, but the patients who are still patients who are waiting a transfer to a different facility, I think we've already heard comments that that space needs to soften that transition point. So I think if we don't already have a comment in about access to daylight in those spaces, I think one is coming.
Just to circle back to the initial question though, I don't think that there is that requirement currently in there.
Thanks. What would be the maximum length of stay in either the lounge or transfer unit?
That was an interesting question. When we were at SLS, I think the range for the lounge, and this is folks waiting for a ride, was definitely less than 24 hours. And I think the general sort of heat map landed around the 5 to 6 hour range. I think as you even start stretching that for you need to think about medication and nourishment and a couple of other different complications. The other unit itself, I think, still fell below that 24 hour range, but it was probably a little bit longer, if I recall the comments. Again, nothing is in the current draft that says anything about duration of time. So if you have thoughts on that, we'd love to hear them through the comment platform.
Great. We only have 2 minutes left, so maybe time for one more. Will medication provisions be required in the transfer unit depending on duration of time? I think you just alluded.
Yeah, I think that's really a factor of time. That was a great point made at SLS. And I think, especially with the transfer unit itself, that safety risk assessment is going to need to define that for the particular patient population. But no, right now, let's see. I don't think we have a medication storage. We say something about nourishment, but do we say anything about medication in the
I don't believe
transfer
so.
lounge?
I think it's just about nutrition.
Again, great comment.
Mm-hmm.
Oh, there's another question. Are there any talks about adding cystoscopy procedure room back into the FGI?
I have not seen anything. Have you, John?
I have not heard anything, no.
Mm.
Sounds like a great proposal for next cycle. A little bit late now.
You know, I want to go back real quick to the question about medication there. I want to make sure that, I can't remember if John mentioned this or not when he was going over it, but there is a requirement that nurses have to have eyes on. So while there might not be a medication station right there, there is at least a way to call for help and make sure that if, you know, a patient who might need to be attended to via medication, might be in distress or whatever, there is a nurse who's going to be able to call for help.
Thanks, Heather and John. It was a great presentation, and we're at time. So thanks everybody for attending. Please go into the chat